Hello, I'd like to welcome everyone to the IBM Watson Health Executive Webinar Series. Today's presentation is titled Quality Incentive Programs, the Huntsville Hospital's Experience, presented by Amy Yearwood, Quality Manager for the Physicians Network at Huntsville Hospital. Before we begin, I'd like to review a few housekeeping items. First, you have a control panel on the right side of your screen. You can minimize and expand this panel by clicking on the arrow in the upper right corner. Second, you can submit questions using the question panel located near the bottom of your screen. Today's presentation will conclude a little early at 12:45 p.m. Eastern, so we are going to try to answer as many questions as we can. If your question was not answered, we'll respond to you individually after the event. Next, all registrants will receive a copy of the presentation and a link to the recording within 48 hours after the webinar. The information will be sent to the email in which you registered for this webinar. Next, I'd like to introduce Ms. Amy Yearwood. Amy is the Quality Manager for Physicians Network at Huntsville Hospital in Huntsville, Alabama. She manages and coordinates all quality improvement initiatives and makes recommendations based on lean methodology to successfully implement changes. She is the team lead for the implementation of the patient-centered medical home accreditation for the primary care practices and assists with needs such as ICD-10 education, documentation improvement, and physician quality reporting system measures. Today, Amy is going to cover how Huntsville Hospital tackles measuring and reporting quality requirements. Amy, the floor is yours.
Thank you, Sean. Everyone, again, it's a privilege to be here today, and we thank you for attending this webinar. As we move forward, we would like to talk about our objectives today. Huntsville Hospital has merit-based incentive contracts and our performance categories that Huntsville Hospital uses in our contracts with each provider. And also there's specialties that we use merit-based incentive contracts as well. Just to give us a little history about who Huntsville Hospital is, we're a 941 bed community-based not-for-profit hospital in north central Alabama. We're the state's second largest hospital, and we have 24 physicians network owned practices with about 76 plus providers. The different specialties that we have Huntsville Hospital Physicians Care, Hampton Cove, Lowell Drive, Madison, and Bailey Cove, and Gurley as well. They're all our primary care practices. And then we have Huntsville Hospital's Maternal Fetal Medicine, Lung Center, Surgical Associates, General Surgery and Trauma. We have Neurology Associates, and Tennessee Valley Pediatric Surgery, Pediatric Intensivist and Pediatric Hospitalist. We have Hazel Green Pediatrics, Tennessee Valley Gynecology, Oncology Associates, and we have our North Alabama Hospitalist, St. Jude's Clinic at Huntsville Hospital, Digestive Disease Center, our walk-in clinic, and Huntsville Hospital Spine and Neuro. And we also have our OB and ED hospitalists. So our core protocol that we look at for our incentives for our providers is what specialty they're in, what kind of quality we would like to look at for those providers, what kind of service or patient satisfaction things that we would like to associate with our incentive contracts, and then also the financials. We look to see if our providers are meeting budget and those kind of issues. Here's an example of our surgical associates, and as we talked about before with the core protocol, our quality, our principal weight is 50% of what their incentive pay would be. And our first item is surgical site infections, rate less than the comparative general surgeons on staff. So we benchmark ourselves. The second thing we do is look at and make sure they're in compliance with all the hospital approved and suggested operation room policies and procedures, but it's not limited to just those. The other service area with the principal weight, which is 25% of the pay, is different questions that we use from our vendor for our patient satisfaction surveys. And this, for surgical associates, happens to have these 3 questions. In the last 12 months, when you found this provider to get an appointment, were you able to see the patient, were you able to get an appointment as soon as you needed? The second one, using the number of 0 to 10, 0 being the worst provider and 10 being possible the best provider. And then also in the last 12 months, how often did you see this provider within 15 minutes of your appointment time? So sometimes those questions can be challenging to get numbers, but it also allows us to do some process improvements as far as workflow and better planning whenever we see results with these kind of questions. Now our financial performance is 25%. We evaluate if they meet budget expenses, achieve coding accuracy. Huntsville Hospital just recently went through a coding audit, and so we looked at those results per provider, and we are fixing to actually share those results with the providers to see what kind of improvements we need to make. And also we want to make sure that our providers are submitting their charges within 7 days, whether it's in the inpatient world making rounds or also in the outpatient world, so that we can get our billing out the door like we need to. Another example here is the Pediatric Neurology. We have a tool in our EMR that can actually run reports for meaningful use and some PQRS measures. And this one achieved 60% of CPOE, achieved 50% e-prescribing, provide patient-specific education material, provide a summary of care transition out. And so each of those, we have a percentage that we monitor, and we can see that we can refer back to it, whether it's a monthly, quarterly, yearly report. We can make sure our providers are on target meeting those measures throughout the year. In this particular example, under Pediatric Neurology, on the service part, they have just the one question, overall patient satisfaction, and that goes back to this previous slide where it says using any number 0 to 10, where 0 is the worst provider and 10 is the possible best. That's what the achieve overall patient satisfaction means. And so they're graded on that. The actual time frame that we look at whenever we're doing these quality incentives is July 1 to June 30th the following year. And also the coding accuracy was included in this one as well. In our Hospitalist program, we have our different measures here, 30-day readmission rate, and our target for that is less than or equal to the national benchmark. So we want to always compare ourselves to that. Risk-adjusted mortality index with comparable size hospitals. And we monitor our VTE prophylaxis in our eye care. Length of stay, averaged observed versus expected compared to the same large hospitals. If we participated in high-value care team initiatives. And 30-day readmission rate for COPD. One of the things that Huntsville Hospital was part of a grant with CMS, and it concluded right at a year ago. One of the things that we targeted were some of the conditions that we did see with readmissions was congestive heart failure and COPD. So we tag teamed with our hospitalists to help us with some of the improvements that we put in place for COPD, and so we actually added this as a component to see if we were following through with our decrease in our readmission rates. Again, the service, same principle with those different questions. These are a little bit different. How well the hospitalist kept the patient informed about their care and treatment throughout their stay. How well the hospitalist coordinated care. And also, was the hospitalist program explained? Sometimes we have patients that are unfamiliar with the Hospitalist program, and so we want to make sure that they really understand that as we're taking care of them. The other component for the financial piece for the Hospitalist is they meet their work RVUs for the national region for MGMA, and we look up that to see if there's any changes each year. Achieve coding accuracy again, reduce cost per case compared to other internal medicine physicians at Huntsville Hospital, so that's some internal data that we actually use. And the other financial performance piece, manage the program within the national benchmarks for provider subsidy from the Society of Hospital Medicine, so we also use that. We also have them attend a ProAssurance seminar yearly, and then quarterly meetings to make sure they're attending and getting updates of different things as there's changes throughout their program. Here's another example, Huntsville Hospital Neurological Associates. Pretty much achieve 60% of the CPOE, 50% for e-prescribing. On this one, all prescriptions written must include the medication dosage, route, directions, and indication if necessary. And again, we're big on making sure that we provide the patient-specific education material. This is also the same kind of patient satisfaction questions, just varies just a little bit there with the Neurological Associates. Same thing with the coding accuracy. So you can kind of see a theme as we go through under service. It's different questions per specialty for patient satisfaction surveys that we use, and then also financial performance, achieving coding accuracy is similar. Hazel Green Pediatrics, we have 3 on the quality, provide the HPV vaccine for children that meet recommended guidelines within 9 months after the start of the series. We also look at providing reminders for the 11 and 12-year-olds of their preventative visit, and then also if we receive PKU results within 4 weeks. Same process for their service and their financial. Digestive Disease Center, their quality metrics are a little bit different. Body mass index to make sure it's documented on the patients at least 95% of the time. Achieve adenoma detection rates of 15% for colon cancer screening. Achieve colonoscopy withdrawal times of at least 6 minutes in 90% of the patients undergoing screening colonoscopies. Colon cancer screening documentation at least 90% of the time. We want to make sure that our medical records in the office and the hospital are completed in accordance to the medical staff bylaws. And also we have requested that our Digestive Disease Center providers do continuous education for the clinical staff and endoscopy, especially if they have new employees as they come on board. That's part of their orientation process. The Digestive Disease Center came on board as an employed practice with us January 1, 2015, so we were in the process of getting them set up with a vendor that could do our patient satisfaction surveys, but we have not. I think we have 1 month's data now, so that just took us a little while to get them started. The other piece we will be adding to them is the financial performance evaluation, but a lot of the digestive disease is based more on quality currently, and it's tied to their work RVUs as well. Our primary care quality changes year to year, and so this previous year we did the diabetic foot exam. Our physician composite star rating for our Blue Advantage Medicare, Humana Medicare, and our Health Springs Medicare programs. And they needed to at least have 3 stars for each of those plans. Blood pressure control, And you can see the measure individuals 18 to 65 with a diagnosis of hypertension whose blood pressure was adequately controlled. That's a large measure for us. Cancer screenings, colon cancer screenings, A1C control for our diabetic patients. Red, white, and blue Medicare wellness visits. And then here's where we partnered with our reduced COPD readmissions less than or equal to 6% for the provider. And this is also in accordance with us tag teaming with a hospitalist. Again, there's the 3 questions for our service for our patient satisfaction surveys. And the financial meets same thing, meets budget expenses, achieve coding accuracy, and medical records completion within 7 days. Here is a scorecard that we put together, and it has, we usually do quarterly so that the physicians can kind of see how they're tracking and trending if they don't have time to go into our system, which is FITEL that we use as our population health tool to get these different metrics from. But with the diabetic foot exams, the physician, all of that was listed on our quality. This is the scorecard where we can actually show them quarterly how they are doing. And then we usually run the 3 months data as well. We also look at, in this segment to the right, if there's a same-day availability for our patients to be seen, the average visits per provider per day, and then we also look at their panel size in Crimson, another tool that we use as well. Our second page, we look at average net medical revenue per physician, also the average expenses per provider, and then days in AR. We're trying to monitor those as well. Again, the coding accuracy is on there, and then also the medical records. So the segment to the right, you can see year-to-date budget financials, current charges, and then total collections. We look at those as well. We look at their current RVU rate, work RVU rate, and then a scheduled appointment time. We look and see if there's a standard total minutes for each appointment, if we're kind of along the bell curve or if we're off the bell curve. So Huntsville Hospital has been trying to meet the challenges of measuring and reporting quality through several different initiatives. And so we have been, like most facilities, we have been participating in meaningful use. And then we also monitor each provider's quality based on the specialty, as we discussed. We also, the quality incentive contracts are in place with most of the employed providers, and we do renew them yearly. Reviewing new EMRs is a big thing for us. Our current EMR, the functionality is there, but it is cumbersome like most EMRs, so we do have some challenges with it, with our reporting capabilities and data extraction. And our patient satisfaction results, we use those to drive some practice improvements. Huntsville Hospital is currently, for the Physicians Network, in the process of applying for the National Committee for Quality Assurance, the NCQA recognition for the Patient Center Medical Home at our Hampton Cove site. Dr. James Morrison is our medical director, and he's been a key part of us working towards that initiative to achieve that goal. We have reviews that are coordinated with different payers to see each provider's quality outcomes to make adjustments for the future, whether it be looking at cost of medications, med adherence, high-risk meds, and then different quality scores if there's things that we need to do with each payer, or if it's just something that we can provide more information to the payer so that it can reflect in their quality as they take care of their patients. So with Huntsville Hospital already having incentive contracts in place with most of our providers, it has really teed us up to be ready for the change as meaningful use in PQRS transition to and is relabeled into MACRA, or the Medicare Access and Children's Health Insurance Reauthorization Act of 2015. And as most of you know, as of January 1, 2017 is when all of these things with the meaningful use PQRS are coming together and will start being the year that we're monitored for our performance. So based on this, the quality is huge, and so we already have a lot of that built into our contracts. The other thing is advancing care information, which is the relabeling of the meaningful use and how we are using our measures electronically across the board and what kind of information we can get on our performance. The other part of that is clinical practice improvement initiatives. So we can use different things as practice improvement initiatives. There's a list that can be seen at the site listed below for the different activities. There's 90 you can choose from for the medical home to earn full credit in this category. And there's also those that are participating in advanced payment models can earn at least half credit if you're doing that. Also, the cost, CMS is going to calculate the measures based on the claims. So the average score of all cost measures that can be attributed will be a percentage of this as well, going towards MACRA. And as we look at our budget and our incentive contracts, and then how each of our patients with our payers that actually will give us some information to review from, we can see how our cost containment is, cost utilization across our patient population. Some of the different additional resources that I've seen that can help drive some of the information that you can use in incentive contracting is these sites that has been very beneficial to our education as we're trying to educate our providers and what we need to do to adjust accordingly for the changes in healthcare for January 1 of 2017. And that's a lot of information, and it's pretty fast. I talk quickly, so I apologize if I've spoke to something too short. But at this time, if anybody has any questions, we'll open the floor to that. I will say that the Quality Incentive Program will be taught more in depth at the IBM Watson Health Population Health Conference in Dallas in December as well. So back to you, Sean.
Yeah, at this time you can submit questions using the question panel located near the bottom of the control panel. We'll take a minute for the questions to come in through the queue. And Amy, I can go ahead and give you a couple of questions that came in. The first one being, are your hospitalist goals team goals or individual goals?
It's a little bit of both. It's as a team on the quality piece, and then also a team on the patient satisfaction. When it comes to financial and some of the other metrics, it's still a team, but one of them that was very important is there's the incentive individual piece on the payout if they attend the meetings. So it can be plus or minus individually an additional financial amount if they attend.
Okay, another one is, do you track how well the hospitalists are communicating with the primary care or referring medical team?
We do. We actually have a daily admission report where our hospitalists, since they're our key admitters, primarily at Huntsville, that we get it daily, and there's a couple of different ways that we track our. We have a report that does the attending provider, and then also there's a place where we ask who the primary care physician is as well. And so when we get those reports, we look at them daily to see where our patients are and who they belong to and who we need to be touching base with for any kind of transition of care as we go forward.
Okay, the next one is what data sets are you using for analysis of measures?
We have different data sets that we use. I have to use, fortunately, Vital is a population health tool that we use to do our quality metrics in our primary care. We have GE Centricity, that's our EMR, that actually has some functionality in it. We can run crystal reports and different things out of it, but we can also, we have the QSS, the CQR piece that does the meaningful use that we pull the data sets out of, and then also Crimson practice management that we also pull information out of for our work RVUs and those things associated with our for our providers.
Okay. How often are coordinated reviews done with your payers to review quality outcomes?
Well, we do an ongoing, usually it's about quarterly. If there's anything that looks to be high priority, typically the 3 payers that we work with give us feedback, pretty quick as soon as they see something. But normally it's on average quarterly.
Okay, and does your organization have a care coordination team? If so, what initiatives have been helpful in preparing you for MIT?
Our care coordination team is not necessarily titled that. We actually are doing a care management type program that we are in process piloting and putting in place. We do have very good inpatient social workers and case management that helps our patients. The way I mentioned briefly about the daily admission report that we get. So we have team lead charge nurses currently in our practices that get this report, look at it, and try to start the transition of care, the phone call within 2 days, and then try to schedule the follow-up visit from the hospital within a 7 to 14-day window. With that being said, since we've got people doing parts of it, and so we're trying to get better at that. We've also partnered with a team called TARCOG that is also another grant that CMS had initially did that was looking at med reconciliation and having like a team coach, life coach come into the home and do a one-time visit, and it was for 5 counties, so that was the limitation there. But they have been very good to, at least if we identify the patient in the hospital and they have Medicare and they have not been on their service in the previous 6 months, they can go in and visit the patient in the hospital for us, talk to them and see if they're willing for that coach to come out into the home and review medications with them and those kind of things for the one-time visit until they can actually get into the primary care office. And tag teaming with that has actually helped us a great deal. And so that team, TARCOG, has been very, very beneficial to Huntsville Hospital. They will be, I think that their 2-year extension may end in December for us, so that's the reason why we're trying to look at different avenues for a care coordination team. So we're still up in the air, but we hope to have a good care management program that will hopefully have some inpatient care management team members and some outpatient.
Next question is, who in your organization spearheaded this project, and which departments are part of the committee overseeing this work?
Well, Heather Mason is our Director of Physician Network, and I know whenever she's been here approximately 10 years, and so when she started as the director, she was part of the team that started doing the quality incentive contracts or merit-based incentive contracts for our providers. So initially, she actually had started it. It may have been placed 10 years. It may have been in place prior to her coming into that role. I'm not sure about that, but at least the last 10 years she's been key on working with our C-suite individuals as we recruit new providers and start the contracting process.
Okay, great. Amy, I want to thank you for your time today. And as a reminder, you will receive a follow-up email that includes this presentation and a link to the recording within 2 business days. Also, we ask that you please take the brief survey when you log off the webinar to help us learn more about what was effective and where we can improve for our future webinars. At this time, the webcast is ended, and we thank you for attending and hope you have a wonderful day.